warm good evening to one and all. I am Rishi,
And I'm Leah.
host of the day. Today we have gathered here to hear from an eminent personality on the World Zoonosis Day.
World Zoonosis Day commemorates the work of the great scientist Louis Pasteur, who successfully administered the first vaccine against rabies, a zoonotic disease.
Let's start this event by God's grace. I request Janet for the prayer.
Create in me a clean heart, O Lord, and renew right spirit within me. Cast me not away from thy presence, O Lord, and take not thy Holy Spirit from me. Restore unto me the joy of thy salvation, and renew right spirit within me. And renew right spirit within me.
Thank you, Janet. I welcome Dr. Gigi Jacob, head of the Department of Microbiology and Biochemistry, to welcome the gathering.
Thank you, Leah. A very warm good evening to all of you. Today, 6 July, we are celebrating the World Zoonosis Day. It is a global awareness day to commemorate the inventions of vaccine against rabies by Louis Pasteur on 6 July in 1885. This year, the theme is Let's Break the Chain of Zoonotic Transmission. In 2021, it comes once again in the midst of SARS-CoV-2 pandemic, a disease of zoonotic origin. Let us all celebrate the World Zoonosis Day by learning more about the ways zoonosis disease spread and the ways to prevent it. St. Berchmans College is celebrating its 100 glorious years of education excellence, and as a part of centenary festivities, the Department of Microbiology and Biochemistry is conducting a lecture series. Today, being the fourth day of lecture series, we are extremely blessed to have Dr. Valerie E as our resource person to speak on COVID-19 vaccines, a key tool in the mitigation of a zoonotic pandemic. Dr. Valerie E is an associate professor of microbiology and immunology, Department of Biomedical Science, Philadelphia College of Osteopathic Medicine, Georgia, USA. She earned her PhD in infectious diseases, studying the basic virology and immunology of Pox viruses. She utilized genome-wide RNA interference screening and a murine animal model to examine the modulation of pox virus replication and viral gene expression along the target identification and validation of potential therapeutic interventions. I am extremely honored to welcome you, ma'am, on behalf of St. Berchmans College and the Department of Microbiology and Biochemistry. Next, I welcome all the teachers, participants, students to this function. I hope this lecture series would be a different experience to all of you to widen your knowledge in the subject. Thank you. Thank you very much.
Thank you so much. Thank you for that wonderful introduction, and thank you so much for having me and allowing me to share in this amazing celebration with you. Let me share my screen.
Thank you.
So just as a starter, I have no conflict of interest, to disclose. And I want to start today's discussion with an overview of the transmission dynamics that we see in zoonotic infections. Zoonoses can involve as many as 4 dynamic phases, and they include what you're seeing here in A. They begin with an enzootic or or epizootic cycle within the animal reservoir. The epizootic is defined as the outbreak of disease where there's an unusually large number of cases, whereas the enzootic refers to that low level of disease that's circulating within the animals themselves. Then there has to be a spillover event. So some force that leads to the actual infection coming into humans. This might result in what we call the stuttering transmission, where there's basically it's self-limiting chains of human to human transmission. Or it could result in what we are seeing today, as well as last year on this World Zoonosis Day, the sustained transmission from human to human with outbreaks. So these zoonotic pathogens are typically classified into 3 stages, and that's according to how transmissible they are among humans. So as you see over here, we're looking at stage 2, 3, and 4. Stage 2 examples that are listed are West Nile virus. This is transmitted by the bite of a mosquito. And then Brucella abortus, a bacteria that infects cattle, and it can be transmitted through ingestion of raw or unpasteurized dairy primarily. Both of these pathogens, however, are grouped in stage 2 because they rarely will transmit from person to person once one is infected. Stage 3 pathogens are examples given are monkeypox virus, as well as Leishmania infantum, or Chagassi, as it's called quite often. So monkeypox virus and Leishmania are, though they're 2 different, we've got a virus and we've got a parasite, both of them produce infections in humans that are pretty apparent. You can see them. They're moderately transmissible from person to person. And with Leishmania, that's transmitted from the bite of a sandfly, and it's got a reservoir in dogs. With monkeypox, there's an animal reservoir in small rodents, typically. Stage 4 now, that includes pathogens that have the potential to transmit very easily from person to person. The examples that you see here are going to be pandemic influenza, a respiratory virus, of course, and Yersinia pestis. Now, Yersinia pestis, which causes plague, is caused by a bacteria. It's not typically going to transmit easily from person to person until it's in the pneumonic form. So pneumonic plague actually is very easily transmitted to close contacts via respiratory droplets. So based on the length of the arrows you see here, you can see that there's a relative number of humans that can be infected and transmitted with zoonotic pathogens within these categories as you increase in length. So if we focus now on the spillover force of infection here at this point, let's first define the force of infection. That's the per capita rate of infection of susceptible humans. We can see here it's determined by the product of 3 major components. So number 1, the prevalence of infection within the animal reservoir. Number 2, the rate at which humans come into contact with these animals. And number 3, the probability that humans become infected when contact actually occurs. So these components are all influenced by a variety of properties that you can see listed underneath. These properties have very important differences, and they're driven primarily by how the actual zoonotic pathogen transmits to the humans. So significant differences can also arise between zoonoses that use wildlife instead of perhaps domestic animals. And so all of these differences that you see end up resulting in differences in a frequency, in the duration, as well as the nature of that cross-species interactions, as well as key opportunities for human intervention. So in speaking of severity of emerging diseases and zoonotic diseases, of which both are very often tightly intertwined. So a lot of zoonotic agents actually cause very little to no signs of disease in the actual host. So if we're starting here in the center, we're looking at viruses. So viruses, of course, as you know, are not the only pathogen group that can infect humans in a zoonotic manner, but many viruses, or many of our outbreaks have been caused by viruses, I should say. So in this case, we're looking at viruses. There's a natural host. Oftentimes it's going to be a bird, or I'll say an avian of the avian species, or often, as we see, especially in this particular pandemic, a bat. But in these natural hosts, these viruses or other agents are asymptomatic within them. And then typically what happens is that they end up getting transmitted to what we call a transmission host. In the transmission host, they might present with disease symptoms. Those symptoms might range from moderate to severe. For example, we may see a pig infected with an influenza virus, an avian influenza virus, for instance, And in the terms of the severe cases, a horse might become infected with Hendra virus. Now, after this, we have what's called the terminal host or the spillover host. And that is us, humans, here. So at that point, we are going to typically present with very severe symptoms and high mortality rates at times. For example, in the case of humans being infected with H5N1, an avian influenza virus. For some of the more recently identified emerging infectious diseases with the zoonotic spillover events, things like the H7N9 or the MERS, Middle Eastern Respiratory Syndrome, or SARS coronaviruses, the original SARS coronavirus, which we'll talk about briefly shortly. In some cases, we've identified the natural host and or the transmission host, but there's still question marks. So coronaviruses themselves, let's talk about them. Coronaviruses are actually not typically considered pathogenic. They are, or excuse me, they're not considered highly pathogenic to humans. That was until we saw SARS as a coronavirus that circulated in humans, causing severe infections. Prior to that, as long as you were considered immunocompetent, you typically did not experience anything besides a mild respiratory illness in, when infected with one of the 4 coronaviruses that you see. Sorry, my pointer is choosing not to work with me. Okay, give me one moment to fix the pointer. Well, it may not, oh, there it goes. Thank you for that. So when you see here, these 4 coronaviruses caused that mild respiratory infection in humans. Then when we saw SARS and then that Middle Eastern respiratory virus, that's where now, instead of having the upper respiratory infection, which is that common cold, we're seeing that severe lower respiratory tract infection. And then SARS-CoV-2, which also can cause that severe lower respiratory tract infection, as we all know, as well as in some that very mild respiratory illness. So these viruses belong to the Coronaviridae family of viruses. They are positive sensed single-stranded RNA viruses. These particular viruses can cause gastroenteritis in animals as well as what we've just described in humans. So there are alpha and beta coronaviruses, which are the ones that infect mammals and particularly humans. And then the gamma and delta coronaviruses infect birds and fish and, at times mammals. Forgive me. Okay, so the zoonotic origins of coronavirus must be discussed. So I just showed you that we've got 4 coronaviruses that infect humans and causing mild disease. We have 3 additional coronaviruses that cause more severe disease. Now, in this particular graphic, what you're looking at are the solid lines where we have the confirmed data of the natural host absolutely going to transmit to some sort of intermediate host. If it's a black line, that means that's the infection in the intermediate host. If it's in yellow or orange line, we're looking at a mild infection to humans when it comes to us. And so that's what we're seeing here with those 4 that cause the seasonal colds. And then when we're looking at the red lines, we're looking at that severe infection in humans. So that Middle Eastern Respiratory Syndrome coronavirus, the MERS, as you can see here, the bat was identified, the dromedary camel as the intermediary host was identified, and it caused a severe disease in humans. With SARS coronavirus, horseshoe bat identified, the palm civet being the intermediary host, which then transmitted to humans. Now, as we're looking at the SARS-CoV-2, with this being so new, we're going to talk about it as the potential origin. So it is a zoonotic transmission of this, knowing that it is a coronavirus and understanding and doing phylogenetic analysis, we know that it is a zoonotic transmission, most likely having been transmitted from bats. And the pangolin has been associated with being an intermediary host, as well as several other mammals, from small to larger mammals, have been potentially implicated here as being the intermediary to transmit to humans. In the beginning, we knew that direct contact, person to person, as well as direct contact with contaminated surfaces, could be one way that this virus is spreading. And then we found, of course, that small droplet transmission, that respiratory transmission, was key to really spreading this virus and allowing for that human to human transmission to occur very easily. There are other theories and potential origins that the World Health Organization is exploring, as it could it be a potential laboratory exposure, an accident, the lab leak theory that we hear about. These are less readily discussed mechanisms. We've seen with other zoonotic transmissions that zoonotic infections, excuse me, that there have been transplacental and potentially perinatal transmission. But ultimately, what we're looking at is it is a zoonotic transmission. There had to be some sort of intermediary host, and the most efficient means of transmission from human to human is via that small droplet. So bringing those last two slides together, I like this particular one because it shows the real common origins for many severe diseases. So while it may be different bats that you see as being the asymptomatic primary host, you see in all cases, and on here, we're also looking at Nipah virus and Ebola virus as additional examples. So it's not just restricted to coronaviruses, but we see that there is this transmission event that happens in one of several ways to an intermediate host, and the human gets infected. So why did SARS-CoV-2 cause this pandemic? The other coronaviruses don't specifically do that, have not specifically done that, I should say. So some key factors here is that SARS-CoV-2 causes lower pathogenicity, meaning it does not cause as much disease in humans as SARS and MERS, for instance. And it transmits pretty moderately between humans. The other thing is that you have so many people that are asymptomatic or mildly symptomatic, and either way, they secrete the same amount of viral load when they are transmitting. So it doesn't actually matter if somebody's severely ill or somebody's mildly ill, they're still able to transmit. And then when somebody's asymptomatic, or as we've seen as this pandemic has evolved, there are individuals that have atypical clinical manifestations. It's quite difficult to diagnose. And so that's an opportunity where physicians or even themselves individuals may not recognize that they may need to go get tested because their symptoms don't look as clear-cut as what's being broadcast as the majority of people. So then that brings in challenges with quarantining and contact tracing. And then, of course, we had this global population that had no prior immunity. So in that case, this virus had an opportunity to spread through the entire population. Travel enabled global spread. We know that, we are an increasingly global world. It's quite amazing that I am sitting here in Georgia talking with you all in India. But if not for this pandemic, hopefully I would be in person with you one day. And that's how easily we spread, things spread. So that significant human to human transmission, independent of that animal human transmission, is what allowed for SARS-CoV-2 or COVID-19 to cause a pandemic, whereas the previous coronaviruses were not as readily able to do so. So I want to talk a bit, as complicated as it is, about the actual origins, the beginning, and just highlight a few key points, because this is a situation where everybody has worked extremely hard and extremely well together to come up with these milestones. during extremely challenging conditions. So that's the medical community, the scientific community, and the general public. So within a month of the outbreak, 28 days, we actually were able to identify this virus being a novel coronavirus. And eventually it was called SARS-CoV-2. That was a month after the first patient developed symptoms of the specific coronavirus in Wuhan, China, that were brought to the attention of the authorities there. And then with an additional cluster of cases, these atypical pneumonias, China alerted the World Health Organization. And so by December 31st, the world was put on notice that there is something going on. They very quickly shut down that seafood market that they initially implicated in the spread. The first death occurred early in January. The first case outside China occurred in Thailand just a few days later. There was basically an entire quarantine in Wuhan and other parts of China within a very short time. But by the end of January, we had seen already 132 cases, deaths, with 6,000 new cases reported. Now, this is a lot going on this slide. The point of this is, it delves a little more deeply into the fact that by December 8th, for instance, there were 41 confirmed cases of that novel coronavirus in China. However, what I want to highlight here is, in addition to, we saw that very early on, this virus spread throughout the world pretty readily, that the initial burden and the heaviest burden was, of course, within China. And then as a result of notification and that early identification, the rest of the world was able to enact some mitigation to minimize some of the burden within. But while this began as a zoonotic pandemic, we know this now. We assumed it once we recognized it as coronaviruses, but there was no time to fully identify all of that. It was about determining exactly where it came from. There were additional zoonotic and reverse zoonotic transmission. So for instance, we saw that in Belgium, there was possible transmission of COVID-19 to a domesticated cat from the owner who had COVID-19. In April, the Bronx Zoo in New York City actually had a tiger, as well as several other lions that exhibited symptoms of COVID-19 and then later tested positive after their handlers tested positive. There were additional, there was a case of a dog in Hong Kong that you can see in February that actually, as well, not just one dog, but several dogs from, again, owners who were sick and transmitted to their pets. So this is a situation where readily transmissible from human to human, not as readily transmissible, but not impossible from humans to their domesticated pets. So we've got the mysterious illness. It spread, cases multiplied. By mid-March, the world essentially shut down. And we did this thing called flattening the curve that everybody began to talk about. So, we were able to stop that steep curve up, slow it down in many places around the world. And then we were able to begin to open up or reopen in various phases. With the research continuing to identify treatments and vaccines, eventually there was hope. There was light at the end of the tunnel. Everybody was making, well, not everybody, let me not exaggerate. Everybody was holding on to the hope that many nations were exhibiting with the progress with their vaccines, and we'll discuss some of that. But of course, there were new mutations. And so there was that question of, would these mutations affect the vaccines that were in production? So to shift to vaccines, I want to make sure we're all on the same page and discuss a few terms to really understand why we're even talking about vaccines. Why are vaccines this really essential tool to mitigating this specific pandemic, and in many cases, any pandemic, as well as other zoonoses? So R0 is a term you're going to hear, you've probably already heard, but to make sure we're on the same page, it's a basic reproduction number. That's a well-known epidemiological concept which measures the spread of an infectious diseases. And that's defined as the average number of secondary cases that one primary case generates in a given population where nobody is immune and nobody has prior, any sort of prior immunity from natural infection or vaccination. So before, I say previous because this is maybe the first wave, perhaps even the second wave, it was estimated that the R0 was between 2.5 to 3 in many places around the world, including the United States. And so to say it another way, what that means is for every infected person, it was estimated that they would go on to infect 2 to 3 more others. With the current circulating strains, with increased transmissibility, and I'll show you those, we're looking at an estimated R0 somewhere between 3 to 6 at this point. So that's a lot more people to get infected now with these new variants. And I like this graphic because it shows herd immunity, even though many of us do know what that means, we have a concept of it. But what this shows is that when there's no prior immunity, so this is where we were in January last year, really December 2019, no one in the population globally had seen this virus, and therefore at 1 or 2 or 3 infected individuals can go on to transmit very easily within the population and the virus spread. As more people become either vaccinated or immune through prior infection, less and less people, you can see there's a slower spread. And this continues as you move on. There's a corresponding decrease in the level of transmission from person to person. Now what we call the sweet spot would be somewhere here, 75 to 80 or 85% of the population being vaccinated or having achieved immunity through natural infection. And what you see is that the yellow would be those individuals there, they're vaccinated, they're protected, and there's a lot less spread of the virus through the population. This would be a gold standard to reach this 95% vaccination. We've seen cases, we've seen this where populations are protected with the MMR vaccine, for instance, protecting against measles. And so very quickly you can identify an outbreak and shut it down. Now, with SARS-CoV-2, the level of morbidity and mortality is so extreme. We cannot expect that we're going to achieve this level of herd immunity that we need to return to a normal life using just through natural infection. It's too high of a morbidity burden on our health system, on our workers, on individuals, and it's too high of mortality. So on top of that, we have these variants. So how did we come up with those numbers, those R0s, and determine that? Well, there's dynamic models for epidemics. And these dynamic models are oftentimes used to represent key population groups, as well as central processes of epidemic spread. So when we're talking infectious diseases, this differs from chronic conditions. So these chronic conditions might be things like cancer or heart disease or autoimmune diseases. These are all things that are personal to the individual that's experiencing the disease. But when we talk about infectious diseases, that risk of infection depends not only on personal risk factors, but also on the state of other individuals in the population. So we're not in this alone. So as a result of this interdependence, we're seeing that there's lots of non-linear interactions among subgroups in the population. And it's a very complex and at times really counterintuitive sort of behavior that we see with this virus, this specific contagion in an epidemic. So here we're looking at the SIR model. So that's the susceptible, infected, or recovered model, where you've got the host population as susceptible, who then becomes infected. This infected individual can recover, but also this infected individual can go on to infect others that are susceptible. So in B, what we're seeing is this situation where this is the classic model. It's a closed population. What that means is this is an example of no births, nobody's immigrating in. So if this was a closed population and those in black are the susceptible individuals with one individual that's infected, you can see in red, this curve here is the predicted curve, where you would see the tipping point or the threshold if R0 is greater than 0, meaning that one infected person can infect more than one individual. So in that case, you see now there's more infected individuals, but we are also seeing in blue that there's an opportunity now for recovery. As the opportunity for recovery occurs, as the number of susceptible individuals declines now because the contagion has spread through, that's the tipping point. Eventually, the contagion is going to decrease. You're going to have more and more individuals recovered and less susceptible individuals here. So this modeling here is essential to determining what that tipping point is and what is the R0. However, once again, when you throw in the variance, that changes so much. Sometimes I really feel like a doomsayer because I'm giving these talks and it turns out that I end up giving really grim reports. So a lot of people know the facts, but we have to continue on with life. And it's really difficult. So many people have to shield themselves. I have to shield myself from the daily news at times. But when you look at this, here's where we were as of yesterday. 4 million lives lost around the globe to COVID-19, the disease caused by SARS-CoV-2. There's 183.5 cases. And you can see that we're almost at 3 million vaccine doses given worldwide. It's understood globally that these figures are most likely grossly undercounted. So I'm going to shift now to the vaccine landscape. This has been an amazing, amazing journey. Vaccines typically require years of research and testing before reaching the clinic, but in 2020, scientists went on a race to produce a safe and effective Mrna vaccine in record time. So here's where we are. Concurrently, at this moment, there's 94 vaccines being tested in clinical trials on humans. 32 of them have reached large-scale efficacy trials, the final stage of testing as of yesterday's data. At least 77 of them, are in preclinical phases, active investigation. So here though, and that's in animals and other various stages, but in humans, we have 50 that are in phase 1 trials, 37 that are in expanded safety trials. I mentioned those 32 that are in those large scale phase 3 trials. And then 9 have been authorized for emergency use and early or limited use. 8 have been approved for full use, and these numbers are growing. 5 of them have been abandoned after trials. So what I want to do is go over some of the vaccine platforms that we have briefly. So starting with, I'll just put them all on the screen right now. So we've got in the yellow or orange background, these are the vaccines that are being utilized in India right now with the white letters. As we look at the ones with the blue letters, we're looking at the vaccines that are in the pipelines and likely coming to be available for the general public in India shortly. And then in the blue are vaccines that are being utilized here in the United States, as well as other parts of the world. So that would be this one and this one as well. So all of them target the spike protein, but they do so in several different ways. So to start at the top left, we have a platform that is the one that we're most familiar with. In this case, we have a virus-based vaccine. This consists of an inactivated vaccine that's no longer infectious. So Covaxin, which is one utilized there, is one of these. It's made of an inactivated SARS-CoV-2 virus where the spike protein is still antigenic. It can still elicit the appropriate immune response. Similar like vaccines that most people know of and have heard of that have been around for decades would be the polio vaccine, the rabies vaccine, the Japanese encephalitis vaccine. So they're all using an inactive vaccine in this case. As we go on, we can look at a live attenuated vaccine. So there is one that is only one worldwide that has been approved, and that is the intranasal influenza FluMist vaccine that you would spray, and that's a live attenuated influenza virus. However, right now, there's several companies, but there is one that is in the pipelines in trials to be utilized, hopefully, as long as these trials continue to prove safe and efficacious, called BBV154 by an Indian company that I believe it's the company that makes Covishield. Now, this particular one is using an attenuated, meaning a weakened form of SARS-CoV-2, and it would be sprayed intranasally as well. So as you move on, you're looking at the protein-based vaccines. In this case, this is a vaccine that we've seen in lots of different instances. So the injected influenza seasonal vaccine that we get a year is based on just the protein itself that is the antigenic portion. And so Covovax is India's version of the Novavax vaccine, which would be what it's called here in the United States. This vaccine is due to be utilized, or I should say available in the country shortly. Now, viral-like particles are another protein-based vaccine where the HPV, human papillomavirus vaccine, utilizes this platform where the antigens on the outside of the virus are allowed to come together, make it look like a virus, but there's no genetic material on the inside. Now, if we move to the viral vector vaccines on the top right, we're looking at an alternate virus, which has been rendered replication deficient. And this particular virus has the gene inserted for instance, the spike protein. We've seen this virus utilized at the end of 2019. We have a vesicular stomatitis virus that exhibits the Ebola antigenic Ebola viruses, and this vaccine has been approved using this platform. And so several vaccines are using this viral vector platform for SARS-CoV-2. So we've got the AstraZeneca vaccine, which your version is called Covishield, the Sputnik 5 vaccine, the Johnson & Johnson vaccine. All of these are based on an adenovirus, which causes the common cold, that vector, which has been rendered unable to replicate, and then the spike protein for SARS-CoV-2 has been inserted. And then you've got some examples that we've never seen yet or necessarily had approved yet for human use, like DNA vaccines and the Pfizer and Mrna, which are the RNA vaccines. So in this case, we're looking at a situation where you've got the DNA and or RNA, which is engineered to specifically produce that spike protein, and then it is injected. So lots and lots of different platforms that are available. There's advantages and there's disadvantages to them. And if we have time later, I can go into some of them, but I want to compare these particular vaccines that are available for you now in your country. So you've got the Covishield vaccine, which is based on the AstraZeneca vaccine, as well as the Sputnik, and these two are similar in that they're both based on an adenovirus vector. They both require 2 doses. The AstraZeneca virus, those 2 doses can be given from 4 to 12 weeks. Originally, it was said to be 4 weeks, and more data is showing that at times it may you may get a better immune response by waiting. So between 4 and 12 weeks for the second dose. For the Sputnik 5 vaccine, actually, it is 2 doses given 21 days, but what's different here is that while both doses are an adenovirus vector, it's 2 different vectors that are being utilized here, the second one, and that's to help circumvent, the blunting response that happens when the immune system has seen a vector before. Both of them require standard refrigeration, and both are in use. The Covaxin vaccine is that inactive SARS-CoV-2 that we talked about, that's also given in 2 doses, 28 days apart. Now, the Mrna vaccine is being utilized here in the United States, as well as some other places around the world, given as 2 doses 28 days apart, can also be in a standard, in this case, freezer. In April 2021, India has authorized that vaccines that have achieved emergency use authorization in other nations could be utilized within India. And so both Pfizer and Moderna fall under that. And there is, it is in the works that the Mrna Vaccine should be available in India very shortly, within a couple of weeks, in fact. And the Covovax vaccine, which is the same as the Novavax vaccine, is a protein subunit, again, 2-dose vaccine, standard refrigeration. And the expectation is that as production is ramping up now, it would be available for you in September. So to compare really quickly, the viral vector DNA vaccines, so this is, for instance, the ones that are already being utilized. They're the ones that are the adenovirus vector that cannot replicate, that has a spike protein in there. It would be injected, taken into the cell, brought to the nucleus, and the mRNA transcribed. That mRNA leaves the nucleus, and then it's translated into the spike protein, in which case your immune cells, your antigen presenting cells, can pick it up and begin to make the appropriate immune response. The mRNA vaccine, the Moderna, which is coming, as well as the Pfizer that you hear about, is actually a vaccine where it's just the mRNA, as I described. It's enclosed in a lipid nanoparticle that allows it to stay before not be disintegrated by the enzymes in our body, and it allows it to be taken into the cell. This particular virus never gets into the nucleus, excuse me, this particular vaccine never gets into the nucleus. Instead, is directly translated into the spike protein, and the immune response can take place there. So they work very similarly, but they do have distinctions. And so mRNA vaccines, being the one that's the newest in terms of, though we've been utilizing it now since December, so still just half a year, they've never been approved. These particular vaccines, however, have a long history of preclinical and clinical studies against infectious diseases, as well as targeting non-infectious diseases like cancer, for instance. They've been utilized since at least the 90s, so well over 30 years. There were challenges. The RNA is very unstable, and some of these early vaccines that were trialed also produced aberrant inflammatory responses and not the best immune response. However, with current advances, we're looking at an increase in stability, safety, and effectiveness. And so the benefits are, it's non-infectious as an antigen. As I showed you, they do not ever enter the nucleus. And they're pretty readily developed once you have that DNA template in the lab. So it's a lot faster and quite affordable to standardize and scale this process. So there are distinct benefits. So those are the platforms. This last part of our talk here today, I want to get into the variants and looking at the immune response of what's going on with these variants once the vaccines are utilized. So when we talk about variant, the variant is the virus. That viruses constantly change, particularly RNA viruses, first of all. They're constantly changing through mutation. But when it's considered a variant when one or more mutation is significant enough to differentiate it from others that are in circulation. So it was expected that there'd be multiple variants of SARS-CoV-2 anyway. And of course, we've seen these variants, but not all of those variants are actually considered extremely dangerous. The World Health Organization has classified them into several categories. So we've got variants of interest and concern. So the variants of interest are such labeled because they're specific genetic markers that are predicted to affect the transmission, the ability to diagnose, therapeutic and treat, or escape the immune response altogether. And there's evidence that they cause an increased proportion of cases, or they may have unique outbreak clusters. But when they're of interest, there's a limited prevalence or expansion. Variants of interest can change to a variant of concern when it's specifically clear that there's an increase in transmissibility or they cause severe disease. They may cause a significant reduction in neutralization by the antibodies that are generated in prior infection or vaccination, and they may have a reduced effectiveness of the treatments or vaccines or the ability to diagnose. So this chart here is from the World Health Organization, and what you can see, and there's been renaming, of course, of all of the lineages, and we used to go by these names. So we're looking at, epsilon, zeta, eta, theta, iota, kappa, lambda. All of these have been found in multiple countries around the world in terms of the earliest documented sample, but all of these are circulating in many places, and you'll see some of them when we look at the overview of India. Now, the variants of concern, there are 4 that are recognized by the World Health Organization throughout the world. And we're looking at the alpha strain being so because there's an increase of transmission of about 50% more. So far, the alpha strain has not impacted the ability to treat with the monoclonal antibodies. There has been a slight reduction in neutralizing this strain with post-vaccine sera or convalescent sera. But thus far, the alpha strain variant, while it's widespread, we haven't seen an increasing severe disease with it. The beta strain also has an increase in transmissibility about 50%. And here the beta strain is not susceptible. It has a drastically reduced susceptibility to some of the monoclonal antibody treatments, and a reduction as well in that neutralizing post-vaccine sera. The gamma strain is not susceptible to some of those monoclonal antibody treatments as well. And so some of them are no longer indicated if somebody is infected with this strain, and corresponding reduction in that neutralizing post-vaccine sera as well. Now the Delta strain, the one that takes the news, the one that is most widespread at this point around the world, and in India is high, it definitely has an increase in transmissibility, distinct reduction in neutralization in both monoclonal antibody treatments as well as the post-vaccine sera. However, as of yet, we haven't seen that we cannot use the monoclonal antibodies, or at least some of them. It's just that it's a reduction. So when you look at this particular table, what we're seeing, or chart, excuse me, what we're actually looking at now is the estimated proportion of those variants of SARS-CoV-2 in India. And so what you see is that the largest proportion, approximately 97% of all circulating SARS-CoV-2 that's been isolated and sequenced is of the Delta strain. Additionally, the other 3% are going to be the Kappa strain and some of the other ones that are considered variants of interest. But by and large, with the increase in transmissibility, we're looking at Delta strain here. So I want to go over a couple of words because I want to make sure we're on the same page when we look at them. So efficacy, when you hear that word efficacy, that is the effectiveness of the vaccine in clinical trials. So that's under the, perfect conditions, these typically randomized controlled trials. Now, in the real world, we talk about effectiveness because that is, all right, so if the vaccine manufacturer says that it's, X percentage efficacy, that's great. How does it perform out here? And so these real world assessments can be based on any of these factors that you see here. So all of these vaccines, you might hear, does the vaccine, how effective is it to reduce transmission as one factor, or how effective is it to reduce symptomatic disease, prevent symptomatic disease, or prevent hospitalization or death, or so on and so forth. So when you compare the COVID-19 vaccines that are being utilized now in your country, as well as some that are utilized here in mine and some that are going to be utilized in both, what you see is that against circulating strains, and so these numbers have been adjusted to talk about, the Delta strain primarily, but some of the other strains, we're seeing initially before the variants took hold, we saw pretty decent protection at preventing symptomatic disease or preventing severe disease and death. As you read across, that's how you would read it. Now, when you look at the different strains, alpha, gamma, beta, the Mrna vaccine did have reduced efficacy against that. So did Pfizer, and the Novavax did as well. However, they still proved pretty effective at preventing hospitalization and death. When you look at the Delta strain, the COVID Shield vaccine that you have does show a reduced efficacy with 1 dose. It's slightly better with 2 when the second dose is given. I haven't been able to capture the data for these other 2. However, what we see with the Pfizer, which is an mRNA out of Israel, they've adjusted down and to say that, we're seeing about a 64% protection from a symptomatic disease and a 93% protection from severe hospitalization. So we're still waiting on more data to actually say, exactly what's going on here with the Delta strain. But with this being the strain that is most widespread and growing in prominence everywhere, we see a reduction in efficacy, but it's still a bit promising that there is still some effectiveness here with the vaccines. So which vaccine's safer? Everybody wants to know that. That's really important. Well, ultimately, the vaccines, the current data show that viral vectored vaccines, so those are like the adenovirus vector vaccine, and potentially the one that is the SARS-CoV-2 that's inactivated, that's a different one. You see these typical side effects that you see with most vaccines, any kind of vaccine, not just a COVID vaccine. You see these at a less rate than you do with the mRNA vaccines. So some people like that. However, all the COVID vaccines, by and large, have been deemed safe, and they are continually monitored. But I'd be remiss to not discuss some of the COVID vaccine concerns because they're applicable. So the AstraZeneca, of which you have your version, as well as the Johnson & Johnson vaccine, are both associated. So these adenovirus vectored vaccines thus far are associated with this increased risk of thrombosis with thrombocytopenia syndrome, TTS, in adult women that are younger than 40 years old. Nearly all the reports of this serious condition have happened in women younger than 50, and around 40 is the average age. This involves blood clots and low platelets primarily. So does that make this a bad vaccine? No. What it does say, however, is that women younger than 50 years old particularly should be aware of these very rare risks, but increased risk, and have an option to take an alternative vaccine if it's available. Now, the more recent major serious adverse effect associated with these COVID vaccines have to do with the mRNA vaccines, of which the Mrna vaccine is one. And so we've given out worldwide over 160 million of doses of these particular vaccines. And what has been noted is that primarily in male adolescents and young adults, age 16 years or older, although we are seeing a range from 13 to about 30 years of age in males. More often after they get the second dose, they're experiencing a myocarditis and or a pericarditis, which is an inflammation of the myocardium and the pericardium around the heart. Typically, these individuals, can return to their normal activities. The recommendation by the CDC as well as the World Health Organization is to continue vaccinating everybody once they are able to, of age, regardless of the risk. However, if there's an alternative vaccine, you would give the alternative vaccine. So who and how many are getting vaccinated in India and around the world? Well, as of yesterday in our world in data, we could see that the numbers of people getting vaccinated is growing, and it's growing pretty steeply here in India. So the numbers are, this is per 100 people, 0.4 per 100 people. So actually we're slightly higher, about 0.5 per 100 people. Worldwide, we're looking at 24% of the world's population received at least one dose, with over 3 billion doses administered globally. And every single day we're having almost 36 million doses administered. However, only 1% of people in low-income countries have received at least one dose. And the global cases are rising. So this is as of mid-June, we could see the speed, the rapidity of which these cases are rising. Took 10 weeks to grow 30 million earlier in the pandemic, but only 6 weeks to go the next 30 million here to reach 150 million cases. So it's a steep curve. And so now when we look at cases, we're looking at this huge number of cases, and the circle is showing you the number of relative number of confirmed cases per country. And so we're seeing that the United States leads here, Brazil is second, and India is third, followed a little bit further behind by Mexico and Peru. So is herd immunity, to circle back to that, is it achievable? Well, all of this that we saw just a moment ago tells us that SARS-CoV-2 is probably going to become endemic. And what that really means is that SARS-CoV-2 and COVID-19 will be circulating at some low level in humans for a while. And we can't let herd immunity happen through natural infection because it's too high of a burden on the health system and it's too high of mortality rate. So vaccines are not completely eliminating transmission, but we know that the vaccines are decreasing the rate of severe disease, as well as making a lot of people asymptomatic or mildly symptomatic. The challenge of the vaccination, both globally and domestically, has, the rollout has faced challenge, The variants totally changed the equation. I showed you that, with these variants, we're having a reduced effectiveness with the vaccines, although we still need them, because without them, you're having, of course, a situation where you're going to get infected a lot easier. And with some of the variants, you're going to have an increase in severity. Individual immunity is waned. We've seen that. We haven't yet figured out exactly what it is that's going to lead to somebody losing their antibody response and or protective T-cell response. We know that being immunocompromised is probably associated with that, but we don't have this all worked out. So we don't know who's going to not be immune after a while and how long will it take. We also know that vaccines change human behavior. So more recently, the World Health Organization has come back and made an announcement and said, you know what, if you are vaccinated, please still wear a mask, because what we're finding is that people feel protected and they go back to certain activities and they're hanging around with individuals who are not vaccinated. And with these increased Delta strain, the Alpha strain, we're seeing that there's increased risk of transmission even in the face of vaccination, and therefore we're keeping this spread going. And then finally, vaccine hesitancy is a very, very real part of this equation. People are sometimes scared or have their own reasons for not wanting to get vaccinated. Lots of people ask, do we need boosters? Will we need boosters? We most likely will. The companies are making boosters, but we don't know when. When will we need it? Because we don't know how long immunity will last. So how do we prevent or mitigate the next pandemic? We know vaccines are an essential tool. And if we take this One Health approach of understanding that One Health involves the health of our livestock, the health of our domestic animals, the health of humans, and that everybody and everything is intertwined. Our travel, our farming practices, our deforestation or reforestation, our building, the way that we do things, everything is intertwined. If we stay on surveillance, and if we move quickly as literally a united world, and do what we did in this last year and a half, we can mitigate the next pandemic. I don't know if we can prevent it, but it is definitely worth a try. So with that, I thank you very much. I will stop sharing. If anybody has questions, I'd be happy to take those questions.
Thank you, Doctor. That was one gripping talk about COVID-19 and its vaccines. The session is now open for interaction. I request any participants to put any doubts that they have in the chat box.
Good evening, ma'am.
I see it. Yes.
Yeah, ma'am, should I read out the questions for you?
That would be wonderful. Thank you.
Okay, ma'am. So the first question is, if mRNA vaccine is easier and more effective, then why all of them do so instead of the conventional vaccines?
So the question is why, if mRNA vaccines are, I'm sorry,
Easier.
could you repeat that?
If
Easier?
mRNA
Oh,
easier and more effective.
So mRNA vaccines are easier. So here's the thing. I don't know if you all have heard the saying, but if they say, if it's not broken, don't fix it, right? That's what, that's a saying here. And the thing about that is we've had very effective vaccine platforms in the past. Things like, like I showed you, like the polio virus. We've had the MMR vaccine. We've had, a pretty decent influenza vaccines and other vaccines that are utilized around the world that work. So there wasn't as much of a push to create these other vaccines. Now we needed them, especially where we've utilized them quite frequently. We're in, for personalized treatment for cancer patients, for instance, individuals who have not received any benefit or they've exhausted all actual options that are out there for them, they've had the opportunity to use mRNA vaccines in a clinical trial, sort of emergency basis, and it's proved effective. However, that was on an individual basis in so many instances. COVID-19 was the first time that, with the amount of cases and the fact that the entire world was being affected, we had to go look for something. We could say it was broken, let's find something else.
I'm going to the second question. What do you think, SARS-CoV-2 is zoonotic in nature or non-zoonotic in nature from Wuhan lab?
You know what, I really believe that SARS-CoV-2 is zoonotic in nature. Now, in terms of did it escape or leak in some way, in the sense of some accidental, perhaps somebody was infected and didn't know it and maybe it spread, even if that happened. And for that, I really don't know. But I've really thought about this and I've done a lot of research. Even if that lab leak theory proves true, at the end of the day, it still wasn't created in the lab. We've seen the phylogenetic analyses. We know that it clusters very, very closely with other coronaviruses found in nature, in bats, as well as in the pangolin and a few other small mammals. So even if it's a lab leak, it's zoonotic.
Okay, thank you, ma'am. Many reports comes that J&J, AstraZeneca, and Mrna vaccine occurred blood clots in brain. How to overcome this, which leads to death?
I'm sorry, I think I missed part of it about the J&J and AstraZeneca vaccine.
Vaccine occurred blood clots in brain. How to overcome this, which leads to death?
I see. Yes. Well, I mean, I think that looking at the population of people that research has shown, the studies that, well, not studies, but the case reports, I should say, have shown are most affected by these particular vaccines. I think to avoid, my personal recommendation with like my own children or people when they ask me is, if you fall in the age range, if you are female and fall in the age range of people that are affected, then take an alternate vaccine if you can. If you don't have an option, then you could. It's such a minimal risk. It seems like it's a huge risk. Every life is essential and important, so I don't want to minimize that. However, the numbers really are quite small in terms of the percentage. So it's a very, very small risk. And at this point, treating it, because we've seen it long enough, they know how to treat it. And so the opportunity to avoid death has definitely been growing there.
Okay, thank you, ma'am. Is it that as COVID waves emerge, their intensity is going to decrease?
As the variants emerge?
COVID waves emerge, their
Oh.
intensity is going to decrease.
That's a very good question. So far, we haven't seen that. It is expected that as it becomes endemic, it will most likely, fingers crossed, decrease, because we've seen this in other viruses that tend to circulate after the huge outbreak or pandemic that's occurred. So we would hope so, but we're not seeing that just yet in this particular third wave that many places are in, but it's expected that within a couple of years, most likely.
Okay, ma'am. Why is the side effects of Covishield is that due to the adjuvant or due to the adenoviral vector that is being used is causing this? How to tweak the vaccine to increase its immunogenicity with different emerging variants?
Well, those are two really good questions. So with the Covishield, most likely it's a similar manifestation as what we're seeing with the with the J&J, in that we don't know exactly what it is about the adenovirus specifically that is causing this particular manifestation that we're seeing with the severe adverse effects. Now, in terms of, is it an adjuvant or is it the actual vector? It's most likely the vector, because we're looking at, situations where there's either different adjuvants that are being utilized amongst the different formulations that are being used in various parts around the world, but we're looking at similar clinical manifestations. So it's probably something having to do with the interaction of the actual vector plus probably hormones. When we're seeing that this predominantly female predisposition, it's probably having also something to do with the hormones. And then the second part of the question, I forgot.
How to tweak the vaccine to increase its immunogenicity with different emerging variants?
That's a good question. So most likely with that particular vaccine, well, really with all of them, what we're looking at is it's the spike protein. So it would be about looking at, so with the variants, the mutations aren't all in the antigenic portion of the spike protein. However, closely assessing where the mutations are and including those portions in the vaccine to target the actual variants themselves. So tweaking what component is mutated and making sure that it's matching.
Another participant wants to know about the variant strains appearing during the third wave approaching.
So the variant strains are the big ones. The big strain, our primary dominant strain in your country, is the Delta strain. And that's the strain that as of now has an increased intransmissibility, although it's not yet been quantified, like how we could say the Alpha and the Beta were about 50% easier to transmit from person to person. We still do know from looking at it, out of the UK, they've done the National Health Service has released some data last month that showed that it appeared like around 6 people were getting infected for every one. So their R naught is definitely increased. And then it also, so in your country, it's Delta. In the rest of the world, we're looking at Delta being really, I expect it to take over. Alpha has, is pretty equal in the UK. It's Alpha, and then Delta is their growing strain, growing in dominance. And we're really, in the United States, pretty much just behind the UK. And so right now, our Alpha strain is the dominant strain, and our Delta strain is growing in prominence. Of course, there's other variants, those variants of interest that we discussed. You all have some, we have some, and they're going to continue. But this is what we're looking at. So it appears as Delta and Alpha being the biggest threat, if we will.
Thank you, ma'am. Why is the people who got vaccinated with Covaxin is not allowed to travel abroad? Is it because Covaxin is less effective than Covishield?
That is a good question. I was trying to find the answer to. I don't know. I did not discover this until last night, actually. And so, well, my last night. And so I don't know. I'm a little befuddled. I would hazard a guess and say that perhaps the level of efficacy is not, or effectiveness, excuse me. I told you guys the words and now I'm using it wrong. Perhaps the level of effectiveness in the real world may not be robust enough, but I don't know. I will look that up myself though soon. And if somebody wants to know, you could definitely email me and I will let you know.
Thank you, ma'am. Which vaccine is better for good immunity?
Okay, so actually what's great is all of the vaccines are really good. And what's interesting is, as you're seeing, I think I mentioned with, and I'm sorry, I keep mixing up the Covishield and the Covaxin, but the one, I think it's the Covishield, which is the one that's like the AstraZeneca. And that particular vaccine, as we're seeing, they've seen that delaying it slightly, but going beyond 4 weeks, up to 12 even, actually leads to a stronger immune response. And so it's really good. And if you look at the numbers that I presented, we're looking at the fact that when you're vaccinated with that vaccine, the Sputnik, or any of them, you're protected from a symptomatic disease somewhere around 60% or higher. Again, I don't have the hard numbers because it's the Delta variant is, and really trying to understand it and test it is so new, but hey, I'll take that. That's a really good response. And then if you get infected and you have a symptomatic disease, you're protected from hospitalization, severe disease, and death, over 90% effectiveness with all of the vaccines. So they're all really good.
Ma'am, is there a need to modify our healthcare system and services post-COVID?
Well, I say yes. You know, you know, I read a lot of news globally. So I read a lot, but of course you don't, you know, you read, but are you really getting accurate news? So I do read a lot of news about the Indian health system, and you have the private hospitals and the public hospitals. And I also know here in the United States, I see a lot of how it is. And in other places around the world, ultimately, I think expanding access for everybody in a public manner, regardless of the nation, is essential. We're too intertwined to have people all over the world and in pockets within individual nations being infected and not having an ability to get treatment. It affects everybody. So somehow there needs to be, I believe, an expansion of public access as well as support for these hospital systems and putting them in rural places as well.
Okay, thank you, ma'am. In Pfizer and Moderna mRNA vaccine, why they have chosen mRNA?
So the using mRNA as a potential for vaccine started way back in, I don't know, I guess like the 1990s, first time they were actually able to successfully do it. The thing about it is, if you take DNA, which there are, by the way, some vaccines for COVID-19 in trials right now, but none of them have yet reached a status where we're talking about them as a potential coming out yet, but they're in trials. But if you take the DNA, think about what it does in the cell. So the DNA has to get inside. Let's just say it's injected in the same way that the Mrna or Pfizer vaccines are. It's encapsulated in some lipid nanoparticle because you don't want it to degrade by the body's enzymes. So you're going to inject it. It has to get into it'll get into the myocytes. It then has to traffic into the nucleus. The RNA does that too, but the DNA, or excuse me, the RNA doesn't ever have to go to the nucleus. The RNA actually can enter the cell and be readily picked up by the ribosomes and be translated directly. So it skips that whole nucleus step. It happens very quick. The RNA itself also degrades very quickly. So it's protected by that lipid nanoparticle, but once it's inside the cell, it has just enough time to be translated, and then very quickly it's degraded, versus the DNA has to be replicated, transcribed in the nucleus, exit, then translated, and then the DNA takes longer to degrade.
Okay, ma'am. Going to the next question, would nasal vaccines be more effective than injected vaccines?
I saw that question. That was the first one, and I thought, what a good one. So when you're talking about a respiratory pathogen, so most of the ways that we're getting infected is directly through our respiratory tract. And so the mucosal immunity would be most essential at combating that. However, when you inject, and so when I say mucosal immunity, I'm talking about an IgA immune response primarily, right? So IgA would be in our nasal passageways and our upper airways. And IgA, if it were produced through an intranasal vaccine, then it would be able to quickly neutralize when you come across this virus and inhale it. Right? And so it's very effective. However, when you inject, you're having an IgG response primarily, right? And that's not how you're being transmitted. So that is a great question. It would be very, very effective. The drawback potentially, and the reason why there's only one intranasal vaccine thus far, and that's for the influenza virus, is because what you don't want is, so you weaken the virus, you're attenuating it in order to give it as a mist intranasally. And what you're hoping is that it only does a low level of replication right here. You don't want it to be inhaled down into your lungs where it can cause disease. And so it's a very fine line and a fine balance to ensure the safety of this particular vaccine so that you don't cause harm.
Thank you, ma'am. How long does the effect of the vaccine last in the body?
So right now, the last data, I expect Pfizer, for instance, which was the first vaccine that was available in this country, in my country, I expect them to be releasing data soon. It's about time for the next 3-month release. And in that case, I would expect that very soon, hopefully they say 12 months. The last set of data that they've shown, and this is from people that they had in the trials that they've still been following, was that they still had a strong immune response 9 months out. So Mrna Vaccine, the Mrna company, is a little bit further behind in terms of releasing the data, but whenever they do, it appears to be quite similar to the Pfizer data. And then with the AstraZeneca and Johnson & Johnson, those vaccines, so your COVID shield, for instance, they're a little bit further behind in terms of when they began to be utilized. So in terms of overall data, so far we've seen up to 6 months, but it's still unfolding.
How do Africans, especially not showing symptoms to COVID-19?
How do Africans not show symptoms?
Why do Africans not showing symptoms to COVID-19?
Well, they do show symptoms. I think that not showing symptoms is a very individual thing. So they absolutely do show symptoms. I know quite a few people in this country who are from variety, some from Eastern Africa, some from Western Africa, a variety of nations who have actually become infected symptomatically with COVID-19, but also within their home countries, they know individuals who have. So they absolutely do can become symptomatic just as anybody else can. However, I think that there's a very individual thing in that. I don't know if you all have seen data where blood type, for instance, is associated, certain blood types are associated with lower infectivity, as well as milder symptoms. So type O, for instance, is the one that's associated with less, while type A is the one that's associated with the most transmission and infectivity. Now, that specifically has nothing to do with, you know, what people from one continent versus another, because I don't know what the distribution of blood types are, but I'm just saying that that's one potential factor.
Ma'am, the next question is whether it is advisable to get vaccinated with two different type of vaccines, and in such cases, does the two vaccines interact with each other?
So actually there's studies and trials right now going on, which are utilizing that mechanism there in the hopes that in fact it will boost immunity even more than what we see. So would they interact? No. I mean, any vaccines giving the same I'm saying this all backwards. Giving different vaccines at the same time are not always indicated. So, you know, as you were children going through childhood vaccinations, there were some vaccines your physicians might have said, okay, you can get all these right now. And then some they might have said, no, this one has to be at least a month away from the others, right? And so that sort of system would probably be best, because right now we don't have all the information, meaning space out. If you're going to have a different vaccine, space out the dosing and not have them at the same time. But Sputnik, the Sputnik 5 vaccine is actually, in a way, it's two different vaccines for that same idea. They're both adenovirus. One is an adeno 26 virus. One is an adeno 5 virus. Slight difference, you know, strains of the adenovirus, and they're doing that in order to boost the immune response. So yes, I think that we might see that mixing and matching coming.
How many doses of vaccine a COVID-affected person need to take?
It's still recommended to take 2, or whatever the actual vaccine that you're taking is. So if it's a vaccine that is a 1-dose vaccine, then 1 dose. If it's a vaccine that's a 2-dose, then 2. The caveat is that if you've already been COVID infected and recovered, then when you take your first dose, when you read about side effects and symptoms, you'll probably feel more like somebody who's taken their second dose. But then interestingly, by the time you take that second dose, if you've been infected, a lot of anecdotal data shows that that second dose kind of feels, for your body thinks it's a third dose. You don't feel as much with that one.
Ma'am, is it good to increase the time period between 2 doses of vaccine? And what are the factors which decides this?
So whether it's good or not is something that the authorities who are studying the vaccine, whatever they say at that time would be what would be recommended. So who decides it and what are the factors would be, you know, the researchers, the companies as they're doing their trials. Well, first of all, it begins with the animal studies. In the animals, you test out what the appropriate length of time is between doses to achieve the maximal immune response. So actually injecting, you know, usually starting with some sort of mouse or rodent model and then moving to a higher or larger animal, like say a macaque or, you know, an ape. But you're actually injecting with different time frames in between the doses, and then you're assessing the immune response, looking at the antibodies, you know, looking at the interferon gamma levels, looking at the T cell levels to determine that. And that's why now with more time and more data, they're beginning in humans to see that, hey, it might be better to space out a little bit more for some.
Ma'am, what happens when a COVID positive person takes vaccination without knowing that he or she is positive?
So, of course, you know, as with that question, it sounds as though someone knows that you're not recommended, but you might be asymptomatic or pre-symptomatic at the time that you get the vaccine. And the reason why it's not recommended is because At this point, it's not like you're going to have instant protection from the vaccine, right? So since you already have the virus in your body, your own body is already building that immune response. And what you don't want to do is detract from that immune response. So what happens, because it does happen, people don't know that they're already infected. What happens is that it's possible you won't have as maximal an immune response from that natural infection as you might have initially. Because if you think about it, when you're infected with the whole virus, you've got lots of proteins that are being made, different proteins. And so you can mount immune responses to multiple, as opposed to just the spike protein.
Can a person once affected with anaphylaxis take COVID shots?
Absolutely. The caveat is that if you know that you have allergies to anything, what you should do, of course, is look at the ingredients of the particular vaccine that you are going to be taking and ensure that you don't have an allergy to any of those ingredients. So as long as you do not have allergy to those ingredients, then you can take the vaccine. The recommendation in the United States is to wait 30 minutes after. So you would inform the vaccinator that you've experienced anaphylaxis in the past for other things, and you would wait 30 minutes. They're being monitored under, medical watch to ensure that nothing happens.
In case of chickenpox and some other viral infection, where we have long-term immunity to the disease, we have seen many cases of reinfection in COVID. Why it is happening so in short span of time in affected individuals? What could be the reason?
I think there's a couple reasons. So with chickenpox caused by varicella, you're having a robust infection. Even if you were vaccinated against it, the vaccine is a live attenuated, so a live weakened form of varicella zoster virus. And so you're still getting a robust infection in your body. And that really robust infection causes a long-term immune response. And then the virus itself, so the other thing is, so that robust infection versus a lot of people who are getting reinfected, most of the time they had a mild infection the first time. So they most likely didn't have as robust an immune response. And the other thing is, when you look at variants, the varicella zoster virus is a DNA virus. It's in the herpes virus family, and it is very stable. There's very little mutation that's happening with it. So then you would expect that in 50 years, the antibodies that were raised and the T cells that were raised when you were first exposed are still, if you come across that same virus, it's going to be the same virus, therefore those antibodies will work. As you see with COVID, we're seeing variants. And so with that change, we're having a decrease in in protection.
What are the chances of a vaccinated person to become a carrier?
So when we're looking at numbers, like, for instance, I'm gonna use data that Israel just released, I think 3 days ago. They said that in most of their entire population, a good number of their population has been vaccinated. I think we're looking at somewhere like 70% or more, and it's been with primarily the Pfizer vaccine, the mRNA vaccine. So what they're saying is that in the face of the Delta variant, which is now here, being vaccinated protects you 64% of the time from actually becoming infected. So what does that mean? That means 100 minus 64. So that 34% of the time you might be infected and asymptomatic, or you might be infected and symptomatic. You're somewhere in that realm there. So 34% of the time, if you've had the Pfizer vaccine, you are potentially a carrier, right?
So thank you, ma'am. So we have come to the end of the questions. So any of the participants who wish to ask questions directly can.
Thank you so much. I've really enjoyed speaking with you all and having questions. And I'm here to take any additional questions. I just definitely wanted to thank you.
I think they have finished up with their questions. So thank you, ma'am, so much for sparing time for us and accepting our invitation. Thank you, ma'am, so much. The session is over to Leah and Rishi.
Thank you, ma'am. Now I welcome Mrna to propose the word of thanks.
Gratitude makes sense of our past, brings peace for today, and creates a vision for tomorrow. A warm good evening to one and all. I deem it a great honor and privilege to propose the vote of thanks on this memorable occasion. First and foremost, we thank the Lord Almighty for making today's occasion a resounding success. I would like to take this opportunity to place on record our hearty thanks to Dr. Gigi Jacob, Head of the Department, for presiding over this event. Thank you, ma'am, for your gracious presence and your guidance. World Zoonosis Day is observed every year on July 6th to commemorate the first vaccination administered against a zoonotic disease. The significance of the day is perhaps now far greater than ever before due to the ongoing pandemic. Dr. Valerie E, the speaker of the day, in spite of her extremely busy schedule, is a reflection of the importance that is attached to the commitment of the profession to quality examination. We are grateful for your inspiring lecture on COVID-19 vaccines, a key tool on the mitigation of a zoonotic pandemic. I, on behalf of St. Berchmans family, faculties of the Department of Microbiology and Biochemistry, students, and on my own behalf, extend to you a very hearty vote of thanks for gracing this function and sharing with this august audience your perspectives of this very relevant topic. I owe special gratitude to Bibi Sarah Joan, webinar coordinator, and the faculty members of the department for their valuable contribution, guidance, and encouragement in all our efforts. My heartfelt thanks to the participants from Kerala, outside the state, and all around the world for their evincing interest in participating. Last but not the least, I thank you, my friends, for your cooperation in making this function a resounding success. Once again, I thank you all for your attention. Thank you.
Thank you so much, Mrna. Now, I request all to stand up for the national anthem.
पंजाब सिंध गुजरात मराठा द्राविड उत्कल वंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मागे गाहे तव जय गाथा जन गण मंगल दायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे